Thank you, everyone, for joining me here today. I'm going to talk about forgetfulness, which I'm sure we are all experiencing more frequently than we did before COVID-19 was a part of our lives. So without further ado, let's get started. So I want to start out by talking about memory complaints and what they are, and how that is or isn't different from cognitive decline, and how cognitive decline is or isn't different from dementia, what causes cognitive decline, and how we can treat or prevent cognitive decline. So forgetfulness is a really broad term, right? So this is going to encompass both normal changes as well as pathological changes, by which I mean changes that are explained by some underlying disease process in the brain. So subjective memory complaint is the term that scientists use to talk about people reporting that they believe that they have noticed a decline in their memory function. We could broaden this term to subjective cognitive complaint to encompass other kinds of things, deficits in attention, maybe our math ability is not what it was, these kinds of things. So we talk about subjective memory complaint. Again, this is a person themselves noticing that their memory may not be what it used to. And this is very, very common in healthy, normal aging. So based on studies from all over the world, about 25% of older adults without diagnosed cognitive impairment will report these kind of memory complaints and say that they feel like their memory is not what it used to be. Based on my own research, about half of the people who make those complaints when they are cognitively healthy will never experience any worse cognitive decline. But that means, of course, that about half will go on to have worse cognition. So how can we separate out forgetfulness that might be concerning from forgetfulness that's just part of normal life? So things that we think are not concerning. If we forget something like somebody's name that we used to know, or some fact, but we're able to remember it later, just maybe not as fast as we want to, that's not particularly concerning. Needing to make lists and keep calendars to keep up with your responsibilities, that's not concerning, that's just life. And misplacing things occasionally, not being able to find our glasses or our keys or wallet, what have you. And we find those things, and that's okay. Things that do concern us. So for instance, this is a big red flag. If you are out driving and forget where you are, or forget how to get where you're going or back to your home, that is concerning. That does happen. So you're driving, everything's fine. All of a sudden, you don't know where you're going, how you got there, or how to get back home. Another concerning aspect of forgetfulness is if we repeat the same thing over and over in a short period of time. I'm sure almost everyone has been accused of telling the same stories more than once to people that they know. But if that's happening over like weeks or days, that's just typical forgetfulness. What we're talking about is in the same conversation, I'm going to ask you the same question repeatedly, or I'm going to tell you the same information multiple times, and seemingly not be aware that I'm repeating myself. So those are the kinds of, big red flags that we look for rather than simple forgetting people's names and appointments. And so I wanted to take the time to make the point today that stress is very well known to increase forgetfulness, to be hard on our memory. So right now, don't be too hard on yourself if you have noticed that you are more forgetful than before the pandemic started. Again, stress, grief, anxiety, depression, all things that we are feeling a lot right now are hard on our cognitive function. So if you are feeling, oh boy, in addition to this pandemic, now my memory is going and I have to worry that I'm developing dementia, don't be so hard on yourself. It's very expected that your memory and your cognitive function are not going to be super good right now. So what is cognitive decline? So we consider this a reduced ability to remember things, to organize things, to multitask, to plan, to focus, and to communicate. In the absence of a brain disease, decline typically occurs slowly over time and may not be noticeable. In the presence of brain disease, though, this type of decline can be rapid and profound. So cognitive decline is a type, or dementia is a type of cognitive decline, but not all cognitive decline is dementia. So cognitive decline is definitely considered a feature of normal aging. Mild cognitive impairment, or MCI, refers to clinically significant memory and thinking impairments. Now, this means that you have either objective deficits on cognitive testing, for example, but you don't have dementia. You're still able to execute all of your activities of daily living. You can work, you can do your finances pretty much, you can keep your house, do your shopping, all those kinds of things. So we're functionally intact, but there is some definite clinical impairment when we have MCI. And then so dementia refers to those impairments that we might see in MCI, but they are typically more severe, and then they are also combined with a need for assistance in completing those activities of daily living. But we're careful to separate out needing help in activities of daily living because of physical impairments, right, versus mental impairments. It's important for us all to know that cognitive decline is not synonymous or is not exclusively caused by Alzheimer's disease. Even if there were no such thing as AD, most of us would still experience some degree of cognitive decline as we age. So how do we measure cognition? I mentioned objective cognitive deficits a moment ago. So we're going to measure cognitive function with tasks that assess global cognitive function or specific domains like memory again, or organization, attention. Scoring of these kinds of tests will typically account for age and educational level because we expect those things to make differences on how people do. And these kinds of assessments can be done in person and thankfully over the phone or computer-based, because this is presenting a very big challenge for the field of cognitive aging research because our research participants are in the group of people who are known to be very highly at risk due to COVID-19 infection. And so in-person assessments are possible to do safely, I think, in much the same way that it's possible for you to go to your doctor's office safely. But it is certainly a challenge. And if we can do that over the phone or using a computer-based assessment, that's going to be preferable. So I mentioned, even if there was nothing called Alzheimer's disease, it didn't exist, we would still expect to see some slowing of cognition as we age. And this is just a plot that shows that. The y-axis there, the vertical axis, oh, I forgot I have a laser pointer I can use. Haha, okay. So here, it's showing what's called a composite Z-score. So they have combined a bunch of scores here. So they're testing domains, your spatial reasoning, your reasoning, your memory, and your speed of processing. And we can see that all of these domains are declining over time. Typically in assessing people's cognition, we look for cognition that is more than 1.5 standard deviations below the expected mean. So here the expected mean cognitive score is centered at this 0. And so we can see that even with this cognitive decline that we expect as part of normal aging, it doesn't move into the range of being clinically impaired. It's just something that happens as we age, and probably as the years between us and our active education grow. So what causes cognitive decline? I do want to make a point first about, I keep saying, our cognition declines as we age. Not all of our cognition declines as we age, right? So our knowledge, our crystallized intelligence does not decline as we age, right? Our vocabularies increase with age, the amount of things we know, the history that we know, all of these things increase with age. However, There are structural changes that occur in the brain as we age. We can measure those with neuroimaging studies, for instance, and we can see that there are areas of the brain that start to atrophy, decrease in size, with both disease and with aging. And we know that synapses connect neurons that let them talk to each other. And we start with a whole bunch of synapses. And researchers have suggested that if we were able to somehow survive to the age of 130, we would have lost enough synapses to produce dementia, even in the absence of disease. So we're losing these synapses over time, and they would affect our cognition profoundly if we survived long enough for all of them to be lost. So we think use it or lose it with our cognition. So I mentioned that time as we age, you know, the time of our schooling is further and further in the past. We know that education boosts IQ scores. We know that delays in schooling and early termination of schooling are associated with lower IQ scores. And we know that people with more years of education are typically able to better withstand Alzheimer's pathology in their brain. And we call this cognitive reserve. And so this means that even if I have Alzheimer's disease pathology in the brain, I might be able to compensate for that and reroute the things that my neurons are trying to communicate to each other. And so I might be able to function just fine, even with brain pathology that might cause symptoms in someone else. So again, cerebrovascular disease is another big culprit of cognitive decline, and that's sort of bad news, but it's also good news because cerebrovascular risk factors are the ones that we have a lot of ability to change. So if we think to ourselves that anything that's bad for our hearts is bad for our brains, that's a pretty good lens to view the world through. And this is just a cool image that shows all the blood vessels in the brain. So we think about the brain, sometimes we think about something gray and mushy and full of neurons, but we don't think about the blood vessels that are in the brain, and they're hugely important for our cognition. So hypertension, for example, very common, and high systolic blood pressure above 140 millimeters of mercury is thought to raise the risk of dementia by about 20%, and much more clearly raises the risk of stroke between 1 and 3 times. And having hypertension, especially in midlife, when you are older, so you had hypertension in midlife, now you're older, it's associated with more rapid decline in logical reasoning. I would also point to a big clinical trial that just announced its results, I think, in 2018. It's called the Sprint Mind trial, and they were trying to manage hypertension aggressively to lower the systolic blood pressure below 120 millimeters of mercury. And what they found was that the people who were able to lower their blood pressure, those groups actually had about a 20% reduced risk of developing dementia during the study or mild cognitive impairment. So blood pressure management, for my money, is one of the ways that we really need to manage our brain health. And diabetes, also very common, is another one that's not great for our brains. So high blood glucose in late life raises the risk of dementia and raises the risk of stroke by 50 to 200%, and is associated with a more rapid decline in processing speed. There has been a lot of talk in the research world and in the media whether Alzheimer's disease and diabetes are causally related. Sometimes people refer to Alzheimer's disease as type 3 diabetes. The neuropathological data don't really support that. They really show that if you have diabetes, that you don't have more Alzheimer's pathology than we would expect. You know, you don't really have more than someone without diabetes, but you do tend to have more cerebrovascular pathology, more little infarcts, for instance. Parkinson's disease is out there, of course, and about 50% of Parkinson's patients experience significant cognitive impairment, and there's even a form of dementia called Parkinson's disease dementia. Depression, as I mentioned earlier, will definitely increase your difficulty concentrating and making decisions, will make you experience memory loss and slower processing speed. And so getting treated for those kinds of depressive and anxious symptoms is, we think, helpful for preserving brain health. So Alzheimer's disease is the elephant in the room, and I've mentioned it a couple of times. This is, of course, the most common cause of dementia in late life. It is a fatal disease, currently the 6th leading cause of death. The Alzheimer's Association estimates about 5 million cases in the US and about 14 million by 2050. The numbers here are from the 2011 Alzheimer's Association report, but they stay pretty consistent around this 5 million in the US and then around 14 million US cases by 2050. Of course, this was all pre-COVID, so who knows what will happen. Alzheimer's disease has major genetic causes. For the early onset form of Alzheimer's disease, that's APP, presenilin 1 and presenilin 2. APP is the amyloid precursor protein. And so if you have one of those genetic mutations, APP, PSEN1, PSEN2, you have almost a certain outcome, which is that you're going to develop dementia. The good thing about this is that this should not be a surprise. And so this isn't something that's lurking in your family history. It should be quite obvious that people were very young and becoming demented, and these mutations are quite rare. So overall, this accounts for less than 5% of all people that have Alzheimer's disease. For late onset Alzheimer's disease, the ApoE gene, which is the apolipoprotein E gene, is the big genetic driver of that disease. And we think that, you know, maybe up to 70% of the risk of Alzheimer's disease is genetic through a combination of ApoE and other genes. But 40 to 50% of people that are diagnosed with Alzheimer's disease don't have any of those genetic risks that we know about. And so what we hope is that the remaining risk that isn't genetic is modifiable, meaning we can change it. This is just a figure showing the very long history of Alzheimer's disease as a biological process. So because we are now able to visualize amyloid and tau, which are the proteins that are associated with Alzheimer's disease, on PET scans, and atrophy and things on MRI, we can also do spinal taps and collect cerebrospinal fluid and measure the amyloid and tau that are in those. And so as we do that for younger and younger people, we're seeing that the disease is already there, like decades before we start to see symptoms, right? So this shows when we are cognitively normal, this is probably 10 to 20 years before we start to show symptoms, but already the biological, pathological processes of the disease are moving from normal conditions to abnormal conditions. And then I mentioned MCI earlier. We stay there for 2 to 4 years on average if we develop dementia and then move on to dementia. But about half of people who develop MCI also don't go on to develop dementia. They don't get any worse. So where the science is now is trying to intervene in this period when the disease process is starting and it's accumulating in the brain, but we don't have any clinical symptoms. And so our hope is that we can stop it from happening, right? It's fine if I have the pathology in my brain, I just don't want any symptoms. Oh yeah, so here's my big slide on all the AD treatments that we have, and it's nice and blank because we don't have any, right? That's great. Okay, so we have no treatments for AD. Yes, and it's a huge problem. So this is a slide that figure that we show often, that Alzheimer's disease is one of the only chronic diseases that we deal with in the US that's showing increases in mortality rather than decreases, which is no good. So what do we want? We want to prevent or treat cognitive decline. Can we do that? So I said there were no treatments for AD, but you will see many retailers, either on advertisements on television or on the internet, who are saying, yes, I have just the thing for you to prevent your memory from declining or stop you from getting Alzheimer's disease. I listed a bunch of them here. There's really no evidence, no compelling evidence that any of these work. And I really want to caution people that if you are taking something that you think is powerful enough to stop Alzheimer's disease, it is also powerful enough to hurt you. So we have to be very careful with these kinds of unproven treatments that are available. So again, there's currently no evidence to support the use of any nutritional supplement for the prevention of cognitive decline or Alzheimer's disease. And again, there are supplements, beta carotene, vitamin E, vitamin A, that may be harmful for certain people who take them. For example, smokers, if they take beta carotene supplements, are much more likely to develop lung cancer. So we have to be very careful with these things. So how about, instead of supplements, we just go straight to the source and have a heart-healthy diet? So a healthy diet is associated with better cognitive function and reduced risk of dementia. And weight-related illnesses like diabetes and hypertension, along with central obesity, excess fat around the abdomen, these are all associated with increased risk of dementia. So a heart-healthy diet is one of your best defenses for your brain. So what does that mean in practice? How about we eat some more of nuts, fish, poultry, tomatoes, vegetables, and fruit, with a de-emphasizing frying these things, although it's delicious, right? That's not exactly what we want you to do. And to eat less high-fat dairy, red meat, butter, fried foods, again, simple carbs and sugars. We think this is good for our hearts, it's good for our brains. This is not good for our hearts, and so it's not good for our brains. Exercise is our other best bet right now. So like a diet or a diet that's not heart healthy, too little exercise makes us more likely to develop other illnesses that promote cognitive decline and dementia. And I just want to take a minute to say that, just as humans, we're animals, right? We're animals. We're living in a really unnatural environment that doesn't offer us the natural opportunities for exercise. We don't have to gather our food. We don't have to construct our shelters. We don't have to do any of those things. And so it's very easy to spend all of your time on your couch. And I totally sympathize with that, because you have to make a choice every time you go exercise. You're making a choice to do that. It's not natural. It doesn't necessarily feel good, but it's really important, and that's our best bet. So take care of our hearts, get some exercise. School-age children even benefit from exercise. We see physical fitness is positively associated with academic performance. And in older adults, both those with and without cognitive impairment, exercise and physical fitness are associated with better cognitive function. There's strong evidence to support fitness training as a means of boosting cognitive function, even in older adults who've never, are not regular exercises. Just showing these are different cognitive domains down here. Executive is decision making and organizing. I'm not sure, I don't remember what they're controlled. This is probably a verbal learning task, a spatial task, and again, a speed of processing task. But what we can see is that for all of these domains, the group that was assigned to the exercise intervention improved quite a bit more. And you don't have to go to a gym, which is excellent, because I don't want any of you going to gyms in the current conditions. So just go out and walk. The Honolulu Heart Study, we saw men who were aged 71 to 93. And if they walked 2 miles a day, those men had half the risk of dementia compared to the men who didn't walk 2 miles a day. And in the Framingham Heart Study, daily brisk walks have been shown to be associated with a reduction of dementia risk about 40%. So all you have to do is get out there and walk. 20 minutes would be good. 30 minutes is ideal, maybe 5 times a week. It doesn't even have to be every day. If it's not safe for you to walk, of course, I don't want you to do that if it's likely that you're going to fall. You know, the sidewalks aren't safe, it's not well lit, those kinds of things. But if it's possible for you to walk safely, it's going to have benefits both for your heart and for your brain. And just as a comment, right, if we're exercising, that's fantastic, but anything that we do that requires us to get hit in the head may not be the most beneficial. So this probably doesn't apply to so many of us now, but boxers and football players have to worry about CTE, which is chronic traumatic encephalopathy, and mixed martial arts fighters, but also soccer players and rugby players. So beware of those head injuries. They are not so good for us and our brains. Social engagement, you know, I questioned including this slide because what are we going to do right now these days? But it's true. People who are socially engaged have better cognitive function than people who are not very socially engaged. And so just getting out of your house and, you know, going to restaurants and on trips and volunteering, visiting with your friends and family, these things are good for our brains. So I hope and think that, you know, maintaining our relationships via Zoom and these online things until we can be safely together is probably better than nothing. Mental engagement. So we want to have intellectually stimulating activities, reading and writing, attending lectures, taking classes, playing games, doing puzzles. If you're combining these with other healthy habits like the heart healthy diet and getting exercise, this is going to be most effective. Cognitive training games, brain training, there's really no evidence for these, and you don't see them as much anymore. Lumosity was big, you know, a few years ago, but they don't really do what they say they can do. We just learn how to play the game and get better scores. But as I mentioned about education, cognitive training is actually beneficial. So formal education has effects on IQ and cognitive reserve. And there's a very famous study called the ACTIVE trial. And the reason that it's famous is because it's one of the only ones done in our field that has really shown that it's possible to offer cognitive training and see a long-term benefit from it. So they had about 3,000 healthy adults over the age of 65 in 6 cities, and they were randomly assigned to one of 3 training interventions or to control. They were trained in small groups for 10 sessions that were at least an hour each over 5 to 6 weeks. So this is like taking a class, right? This is not playing a computer game. So in the short term, the participants in those training arms all improved on the targeted cognitive ability versus the participants who didn't get any of those interventions. But 10 years later, the reasoning and speed of processing groups retained their advantage over the control group. And all 3 training groups reported better functional status. So again, being able to take care of ourselves and therefore remain independent in our homes was also better compared to the control group. So it is possible to give some type of cognitive training intervention at an appropriate dose and duration to improve cognitive function, but right now we're not seeing that in any of the computer-based things that are available. But the University of Kentucky offers cognitive training all the time. And so if you aren't using your employee education benefit and you have the time, can you take a class, learn a language, take an English Lit or creative writing course, take a history course, art, geography, music, whatever. This is mental engagement, social engagement, and assuming we're on campus, physical activity, you know, getting back and forth to class. So to sum up, changes in the brain as we age result in cognitive decline. Remember those loss of synapses that happen just as we age. These changes can affect us more if we are not healthy, right? If we have those heart-related conditions, that's going to affect our brains more. AD, Alzheimer's disease, is a significant source of cognitive impairment, but it's not the only one. And we're learning more and more every day about the other brain diseases that are out there. And my final and always message is what's good for the heart is good for the brain. And if you eat a healthy diet and exercise, that's really the best evidence-based strategy that we have right now to prevent cognitive decline. And if it didn't come across in the ages of the studies that I was quoting, it's not too late to start protecting your brain at any age. So if you haven't been engaged in these kinds of activities and you're 75, that's okay. It's not too late. Start walking if it's safe for you to do so, right? Think about learning new things. That's always good for us. Okay, so thank you so much for your attention. I can take questions if we have time. I'm going to stop the share.